So good afternoon. My name is Riccardo Lencioni, and I have the pleasure today to welcome you to this educational symposium entitled At the Intersection of Local and Systemic Therapy in the Management of Hepatocellular Carcinoma, Preparing for the Next Evolution in Multimodal Treatment. Interventional radiology treatments continue to develop and to improve and to play a key role in the management of HCC. However, on the other hand, 10 years after sorafenib, the first drug to show an unequivocal survival benefit for patients with HCC, several new targeted agents, including TKIs and immune checkpoint inhibitors, have been approved or have shown positive phase 3 data. So I thought this was really a very timely discussion today. It's a very exciting time for this malignancy that was supposed to be kind of an orphan cancer for many years. And now I think it's really critical to understand how to best deal with the different options and how to best manage our patients.
The following audio is part of a certified educational activity. Access the entire activity and complete the post-test at www.peerview.com/ZCA. Downloadable slides and practice aids are also available.
I would like to also introduce the speakers that are joining me today. Anthony El-Khoury from USC Norris Comprehensive Cancer Center, who will be the first presenter today, and Riyad Salem, Northwestern University, Feinberg School of Medicine. So with that, I think it's time and we're ready to get started. So I'd like to introduce Anthony El-Khoury, who will be presenting the lecture on gaining a foothold in the shifting treatment paradigm in HCC, selecting and sequencing among established and emerging treatment options. Anthony.
Thank you very much, Riccardo. So what I'm hoping to achieve today is to really educate you as much as possible or refine what you already know about the systemic therapy options available for patients with hepatocellular carcinoma. And this has undergone a major evolution over the last several months, as you know. So just to set the stage, I'm probably the only medical oncologist in this room. We as specialties overlap quite a bit between medical oncology and interventional radiology in taking care of these patients. The patients that we've normally treated with systemic therapy are patients with advanced stage HCC. By definition, patients have BCLC stage C and usually have portal vein invasion or extrahepatic metastases. Now, as we know, patients between BCLC, B, and C, there is a continuum there, and it's not always as clean as drawn in this schematic here. So some patients with BCLC-B present with extensive disease that's quite multifocal and may benefit from systemic therapy up front, versus some patients with stage C may have only branch portal vein invasion and limited disease burden and may receive locoregional therapy. But nonetheless, my talk will focus on patients with advanced BCLC stage C and some of the patients with BCLC-B who have progressed on locoregional treatment or who have extensive disease and should go directly to systemic therapy. As a reminder, for a long time, the only standard therapy that we had, systemic therapy that we had, is sorafenib, which is a multi-targeted kinase inhibitor, which showed improvement in overall survival in the first-line treatment of HCC compared to placebo in 2 international trials, the SHARP trial and the Asia-Pacific trial. So 10.7 versus 7.9 months in the Western trial, and the Asia-Pacific was 6.5 versus 4.2. The hazard ratio for these two were actually quite similar. So the proportional benefit or the magnitude of the benefit was quite the same, but the absolute numbers were different, probably related to the patterns of care between Asia and the West. The toxicities we're all quite familiar with, but that has been a challenge over time with the usage of sorafenib, is that there are common side effects such as diarrhea, hand-foot skin reaction, hypertension, and we've all gotten better at managing these and being proactive at managing them early. So the tolerance has been an issue. Of course, the resistance is an issue. The median time to progression is about 5 months, and patients develop resistance. Also, all these trials, as you know, have been limited to patients with Child-Pugh cirrhosis, so they have good underlying liver function. Now, for a long time, we had multiple first-line trials comparing new therapies to sorafenib that all failed to meet their primary endpoint, until the lenvatinib data, which was recently presented. So lenvatinib is another oral tyrosine kinase inhibitor that is multi-targeted against VEGF receptors 1 through 3, FGFR receptors, RET, KIT, PDGFR. There was a promising phase 2 study which ultimately led to the REFLECT phase 3 trial that compared lenvatinib to sorafenib in the first-line treatment of hepatocellular carcinoma. And this was a non-inferiority study, so it's important to highlight that. This was designed to show that lenvatinib was non-inferior to sorafenib. And it took patients with unresectable HCC who had no prior systemic therapy. They were BCLC stages B or C, Child-Pugh, good performance status. Now, of note, the study did exclude patients who had over 50% disease in the liver or had main portal vein invasion. You see the stratification factors. It was a 1-to-1 randomization to lenvatinib versus sorafenib with a primary endpoint of overall survival. And here are the results. The median overall survival with lenvatinib was 13.6, sorafenib 12.3. You see the confidence intervals overlap. The hazard ratio is 0.92 with an upper limit of the confidence interval of 1.06, which is less than the predefined limit to meet non-inferiority. So in short, lenvatinib was shown to be non-inferior to sorafenib in the REFLECT trial. Here you see the radiologic response. For lenvatinib by modified RECIST, the overall response rate was 24% and 9% for sorafenib. This is, of course, higher than what we're used to with sorafenib, which is usually 2%, but this study used modified RECIST, and that is probably why. And you see the waterfall plot, which clearly highlights that it's more favorable for lenvatinib than sorafenib. Now, does that really mean very much? It depends. It's the eye of the beholder. Historically, we've questioned how important response rate is with systemic therapy in HCC, because frequently phase 2 trials that showed a promising response rate did not translate into an overall survival benefit in phase 3. But this is a phase 3 setting, and certainly there may be a benefit to the higher response rate in specific patients, depending on the specific clinical situation. As far as adverse events, they were quite comparable between lenvatinib and sorafenib, no surprises. In the red boxes, you see the main differences is that lenvatinib had a higher frequency of hypertension, whereas sorafenib had a higher frequency of hand-foot skin reaction, both expected and known toxicities. So at this point, the lenvatinib data is under review at the FDA, and if that is approved, we may have another first-line option that's been shown to be non-inferior to sorafenib. Now, what happens after sorafenib? And as you know, for a long time, we had no post-sorafenib options until the regorafenib data from the RESOURCE trial came about. This is, again, another multi-targeted kinase inhibitor. You see all the targets listed. This is a close cousin of sorafenib, but there are some differences. For example, regorafenib can target TIE2 and some other specific tyrosine kinases that are not normally targets for sorafenib. There are also some differences in the metabolites and the PK of the metabolites, which may explain why regorafenib worked post-sorafenib. Nonetheless, let's see the data. So this was the RESOURCE trial, which took patients who had documented radiologic progression on sorafenib. and they were randomized in a 2-to-1 fashion to regorafenib or placebo with a primary endpoint of overall survival. Of note, these patients must have tolerated sorafenib, so it was an eligibility criterion. They should have tolerated 400 milligrams daily or higher for the last 20 of 28 days prior to progressing on sorafenib. So these were not patients who could not tolerate sorafenib, important to remember. And these are the results. There was a significant improvement in overall survival with regorafenib post-sorafenib with a median overall survival of 10.6 versus 7.8 months and a hazard ratio of 0.63, very reminiscent of what we saw in first line with sorafenib in the SHARP trial. As far as tolerability, typical side effects for a tyrosine kinase inhibitor was hand-foot skin reaction, diarrhea, fatigue, hypertension, anorexia. Incidentally, the frequency of liver-related adverse events was not significantly different between the two arms, slightly more frequent elevations of bilirubin, but did not translate into more liver failures or anything. Incidentally, what we don't show you here for the regorafenib study, that the study also showed doubling of the PFS and improved response rate with regorafenib compared to placebo. The other intriguing data that was exploratory data is that with the sequence of sorafenib and regorafenib, when those patients were analyzed, the median OS with the sequence of sorafenib followed by regorafenib was 26 months, whereas the sequence of sorafenib followed by placebo, the median OS was 19 months, and that was definitely intriguing data. More recently, at ASCO 2017, the data from Cabozantinib was presented. This is another oral multi-targeted kinase inhibitor that targets MET, AXL, and VEGF receptor 2. There was also promising phase 2 data, which led to this phase 3 trial that took patients who had up to 2 prior lines of therapy, but must have been exposed to sorafenib, and they were randomized in a 2-to-1 fashion to cabozantinib versus placebo with a primary endpoint of overall survival. And again, this is a positive trial showing that cabozantinib had an improvement in median overall survival to 10.2 months compared to 8 months with placebo. A third of these patients were actually third-line patients. They had 2 prior lines of systemic therapy, which is honestly a new territory in hepatocellular carcinoma that we never had before. As far as the tolerability, you can see here a summary of the grade 3 and 4 adverse events, hand-foot skin reaction again, hypertension, some elevation of liver enzymes, and more frequent diarrhea with cabozantinib compared to placebo. Now switching to immunotherapy, and a quick reminder that, and we're going to oversimplify things here, but the cancers have a way of inhibiting the immune system and preventing the immune system from having anti-cancer efficacy. And one of the ways by which they do that is by overexpressing what we call the checkpoints, so PD-1 and CTLA-4, and that's a way to regulate the T cell and prevent it from being active against the cancer. It also has a role in normal immunity as well that we won't go into. So there are now antibodies, which we know as the checkpoint inhibitors, that are targeted against CTLA-4 and PD-1. And when those engage with CTLA-4 and PD-1, they prevent the inhibitory effect of the PD-1-PDL1 interaction or the CTLA-4-B7 interaction, and then reinvigorate or repotentiate the T cells to act against the cancer. So here I present the results of the CheckMate 040 trial, which evaluated nivolumab, an anti-PD-1 antibody, in patients with advanced HCC. There were 2 parts to this trial, a dose escalation part with 48 patients and a dose expansion with over 200 patients. You see to the right the 4 expansion groups, sorafenib naive, sorafenib progressors, hepatitis C infected, hepatitis B infected. The quick summary from the dose escalation is that we had no surprises as far as toxicity, and the recommended phase 2 dose was the same as in other tumor types, 3 milligrams per kilograms, and later the fixed dose of 240 milligrams Q2 weeks was adopted as well. So no surprises in toxicity. What about efficacy? If we look at the expansion cohorts, the over 200 patients, the overall response rate by RECIST 1.1 was 20%. The response rate for the subgroup of patients who were sorafenib progressors was almost 15%, 14.5%. If you look at this table, you see that the activity, the responses occurred independent of etiology. So there were responses in Hep B infected, Hep C infected, and uninfected patients as well. What led to the accelerated approval of nivolumab in September 2017 was this response rate, but coupled by the durability of the responses, which I'll show you shortly. So here in this graph, you see an analysis of the time to response and the duration of response. And this is looking at the sorafenib naive patients and the sorafenib experience from the escalation and expansion cohorts. And you see where the sorafenib naive patients, the median duration of response was 17 months. So those patients responded, and the response was quite durable. And similarly for the other groups, the median duration of response ranged between 17 and 19 months. The responses occurred early. The median time to response was between 1.4 and 3 months. What about survival data? This is a single-arm trial, so there is no control arm, but nonetheless, in the 80 patients who were sorafenib naive, the median overall survival was almost 29 months, and then the sorafenib experienced patients, the majority of whom were progressors, the median overall survival was 15 months. So intriguing, promising data. As far as the adverse events, there were no surprises. The adverse events were typical of what we see with checkpoint inhibitors and other tumor types. You see that the majority of grade 3 and 4 events were laboratory abnormalities that were transient and asymptomatic, and grade 3 and 4 events occurred in only 18% of patients. Now, there's data from pembrolizumab, another anti-PD-1 antibody. This is a single-arm phase 2 study as well with over 100 patients. And you see that the response rate here was 16%. So very consistent with the nivolumab data and gives credence to this approach in hepatocellular carcinoma. As far as adverse events, they were again quite similar with rash, fatigue, diarrhea, and some elevations of liver enzymes. A reminder with immuno-oncology agents that as I tell patients, the immune system can overshoot and cause autoimmune complications. So it's important to remember that those can happen and they have to be watched for, and steroid therapy may have to be initiated for those types of complications. But certainly there are differences in the safety profiles between the targeted therapies and the checkpoint inhibitors as listed here. Where are we going moving forward? This is a first-line phase 3 study comparing nivolumab to sorafenib. This study has completed accrual, and we are awaiting the data, which hopefully will be released within the coming year. This is a second-line study comparing pembrolizumab to best supportive care. This was launched, of course, before the data with regorafenib and cabozantinib. This also has completed accrual. So we have 2 phase 3 data with immune checkpoint inhibitors that are pending. This is the phase 3 focus trial, which is a reminder that there are other immunotherapy approaches besides checkpoint inhibitors. So this is Pexavac, which is a modified vaccinia virus that is intratumorally injected and is supposed to trigger anti-cancer immunity that way. This is a phase 3 trial. Now, there are combinations of immunotherapy agents given together. So this is a first-line phase 3 study combining anti-PD-L1 with anti-CTLA4, the durvalumab-tremelimumab combination, and comparing that to sorafenib or durvalumab single agent. And this is from the Checkmate 040 trial, just to remind you that there are combinations of nivolumab plus ipilimumab, anti-PD-1, anti-CTLA4, and then a triple combination of the anti-PD-1, anti-CTLA4 plus cabozantinib, a TKI. Now, there is ample rationale for other combinations with immunotherapy, including immunotherapy together, like I showed you, locoregional therapy with immunotherapy, vaccinations, and epigenetic drugs. And there is specific rationale for actually combining locoregional therapy, which is close to your hearts, with anti-PD-1 therapy. So locoregional therapy is supposed to, by inducing tumor necrosis, release a higher antigen load, cause damage to liver cells, and maybe actually trigger tumor-specific T-cell responses. There is data to support these thoughts. This is the design of an actually small proof of concept study combining anti-CTLA-4 with partial ablation done at the NCI. So these patients were not candidate for locoregional therapy by itself, but they were given TACE or RFA in a partial way as a proof of concept to release antigens, and then they were given tremelimumab in combination. And the punchline from this study is that certainly with the combination, there was an increase in immune cell infiltration into the tumor. So the patients who had this combination had higher CD3 and CD8 positive C cells in their tumor after therapy. And this increase in immune cells was more accentuated in the responders compared to the non-responders. This is another investigator-initiated trial combining TACE with nivolumab in different schedules as well, and we look forward to these results. So in summary, we have really a new era for the treatment of this disease. You see the FDA-approved options under the green arrow, and then the not yet approved options that have shown a benefit in clinical trials under the dark blue arrow. And we are now talking about multiple lines of therapy, and the challenge collectively for us now is to figure out how to best sequence these therapies and optimize the benefit for all patients. Thank you.
Thank you, Anthony. I thought that was a great talk, and I thought in reality you already addressed one of the key questions, which was how, at this point in your clinical practice, you deal with all these agents. So what would you do? Which is clearly not an easy question because a lot of moving targets. So, yeah.
Correct. It is not an easy question, but certainly in first-line therapy, the current data is still only, as the approved indication, still only for sorafenib. In second-line treatment, we certainly have the option of regorafenib or nivolumab currently, and then hopefully later cabozantinib. So in second line, we can give the patients either nivolumab or regorafenib. One easy separation is that the regorafenib data is from patients who tolerated sorafenib well. So if the patient did not tolerate sorafenib well, we tend to more frequently switch to nivolumab as an immunotherapy agent. Or patients really progress quickly on sorafenib, it may make more sense to switch quicker to nivolumab. But these are actually decisions that we are making based on the clinical intuition rather than solid data. And naturally, what's happening in practice, the agent that we do not give in second line, we end up giving in third line if the patient is still doing well. So we look forward to hopefully more data maturing to help us really sequence these agents better.
Sure. Thank you very much. There was another question that I thought you addressed anyway, but just to quickly touch base, and this is, the question was, are these patients truly able to tolerate TKIs enough to receive a clinical benefit?
No, absolutely. I mean, you know, the benefit from TKIs is from phase 3 data, and phase 3 data is international data, usually across multiple centers. So one cannot say these were only treated in centers where the physicians were experts, etc. I mean, these were treated across multiple centers. I think the secret with TKIs is early intervention on the side effects, early supportive care, adequate dose modifications as needed. And with those interventions, then the side effect profile can become manageable, and then hopefully the patients derive the benefit.
Sure. Thank you very much. And of course, I think the big challenge will be in the next few months and probably years to really understand how to deal with the different agents, hopefully to understand who is truly having a benefit from what. You touched base quickly on response that with modified RECIST, we now can see, at least in a significant proportion of patients. So we would like to understand how to deal with all this information while managing patients. But it's very interesting that you also noted that you do have patients now potentially for third line, which look like something relatively odd, if you think, because initially the idea was that, you know, at some time point there was probably room for at least one attempt, and there was very little even in second line, and now you are talking third line. So it's very interesting, and clearly a lot of new information will become available soon. With this, I would like to invite now Riyad Salem, whom you know very well from his pioneering work in IR and especially with Y90. He will touch base on where local and systemic therapies meet, selecting modalities, timing transitions, and evaluating potential combinations in personalized treatment. So it's really like a kind of a critical talk to understand how, at this point, interventional options will best interact to develop a strategy for patients with HCC.
Thank you, Professor Lencioni, and thank you for the opportunity to sort of give the interventional radiology perspective. And you have seen this chart probably no less than a dozen times, probably on a daily basis here. And this really sort of serves as the framework for what we are talking about when you're managing hepatocellular carcinoma. But the reason to highlight this, particularly for a group of interventional radiologists, is to see where exactly the role of the IR lays in this table. And pretty much at every stage, there's a contribution that interventional radiology and image-guided therapy can make. And I hope to take you and show you through that during this presentation. So for several years, we had been performing various types of embolization therapies. And in 2002, finally, level 1 evidence was described and published. And this sort of served as the seminal manuscript that demonstrated that conventional chemoembolization improved overall survival compared to best supportive care. And from there, the standard of care for intermediate disease was set as conventional chemoembolization. And at the same time, in the same month, in the same year, a confirmatory study from Asia also demonstrating that conventional chemoembolization over best supportive care was able to improve patient survival. So really something that validated the work that many people had been performing at the time, and again, validating the BCLC-B categorization and treatment of intermediate disease. But if you look at one of those manuscripts in one of those studies, there was a signal there that potentially there was a role for bland embolization, and I highlight this because it is used in many centers. And this is the largest series that describes the role of bland embolization in patients with intermediate and other types of hepatocellular carcinomas. It is a local institutional gold standard, and when you look at these outcomes, they compare with other types of therapy. So clearly, bland embolization is performed in many centers and probably plays a role more than we recognize in unresectable hepatocellular carcinoma. If you move forward with a level of evidence, we move towards drug-eluting microspheres. Are we able to improve on the limitations of chemoembolization by standardizing what we are able to give and standardizing the procedure, the limitation of many of the image-guided therapies that we perform? And the Precision 5 study was the first and largest study at the time to try to answer that question. Can the addition of drug-eluting beads improve on the response rate in patients that have intermediate HCC? Randomized clinical trial, response rate as the primary endpoint, did not meet the endpoint. The p-value trended heavily towards meeting that endpoint, but it was 0.11. But what the investigators were able to identify is a clinically relevant subgroup of patients that had more advanced disease that potentially would benefit from drug-eluting beads. And from there, the idea of standardizing dose and improving technique was born out of this clinical trial. Fast forward now, again, to the same group of high-level investigators looking at the SPACE clinical trial, a randomized clinical trial to see whether now using drug-eluting beads, if sorafenib, seeing as now there has been a rapid advancement in the use of sorafenib in HCC, is sorafenib able to augment, improve on the time to progression that we observe with drug-eluting beads? So again, a randomized clinical trial, about 150 patients per arm, very well conducted, and by guidelines, time to progression as the correct endpoint by central review. The study met its primary endpoint, if you look at it, but one of the issues was the clinical relevance of the time to progression observation, and also that in many cases, because we have intermediate disease, many of the other endpoints were not reached, so the time to macrovascular invasion and extrahepatic disease were not met. And this is something that we struggle with when we look at locoregional therapies, the fact that many of the endpoints are not met, particularly extrahepatic progression. This is something that we observe in the censoring mechanism when we look at some of these data. So it did establish, however, that the combination was safe. This was something that was in question. You can use sorafenib in patients with drug-eluting beads, and that the toxicities were manageable in the intermediate to early advanced patient population. But unfortunately, that clinical benefit, the meaningful time to progression endpoint, was not recognized. And so this is something that sort of established that probably there is no role in that specific patient population. again, fast forward to more types of evidence and data, the idea that what is the relationship of the drug-eluting bead response and outcome compared to bland embolization, and this is the group that implements bland embolization as their standard here. You can see a randomized clinical trial of bland embolization versus drug-eluting bead, small clinical study, about 50 patients per arm, with response as the initial endpoint. But again, the first foray, the initial foray, and the only foray actually, looking at these two things to see what types of outcomes they might observe. And they showed that there's actually no difference in overall survival, adverse events, and response rates comparing bland embolization to drug-eluting beads. And here you see the PFS curves, and you see the overall survival curves. No difference between the two. Again, perpetuating and continuing the discussion of the role of the drug when it comes to treating of hepatocellular carcinoma. And so moving on now to radioembolization, who I think is more germane to this topic because it's more in the intermediate to advanced patient population most commonly, it's very interesting because we now change the mechanism of treatment and the mode of action by now implementing a non-embolic type therapy, and so eliminating the classical post-embolization syndrome. And for years, there had been sort of few single centers that had been working on this, but now there are 4 large phase 2 clinical trials, with the point being here that the centers are able to replicate and if not improve on prior centers' experience, and this now can be implemented in an international setting, which is a reasonable and a criticism of this technology early on. Now, moving a little bit into some niche applications that we find with radioembolization, the concept of the segmentectomy and the lobectomy, we know from several of the ablation manuscripts, including Dave Liu's paper in Hepatology, that shows that when you have lesions that are over 2.5 to 3 centimeters, microsatellites start to form. So how do you deal with microsatellites? Well, you ablate either a larger zone, or if you implement what we call the radiation segmentectomy technique, you perfuse the angiosome, you perfuse that territory, and deal with those macrosatellites. And we were able to describe this several years ago, the idea that maybe you're able to achieve what we call complete pathologic necrosis with very promising overall survivals of 53 months if you are able to implement 190 gray. So this was the genesis of the concept of threshold dosimetry, and the idea that if you implant this, now you can predict complete pathologic necrosis. More interesting to me, and I think to many people, and more contemporary in terms of medical need, is the idea of radiation lobectomy, the idea that maybe we can convert patients that are not resectable up front into resectability because of low FLR. And this is an analysis that we did years ago, which was a time-dependent analysis with the idea that you can not only treat the tumor, but hypertrophy the future liver remnant, and now make patients resectable because, of course, we know there are limited organ availability, etc., when it comes to transplantation. So let's figure out a way to make more patients resectable, and this is what this concept introduces. And again, validated by many groups, the German group, Spanish group, and the French group. So again, many centers replicating these types of outcomes. But very interesting here, and again, maybe very relevant to what Dr. El-Khoury was talking about earlier on, is advanced HCC and portal vein thrombosis. And one of the narratives that is generated by Y90 is, in fact, we are now seeing patients, because of the high antitumoral effect, patients that potentially are resectable after treatment with a locoregional therapy where there is tremendous response and hypertrophy. This is a case actually that will be published in the JCO alongside the Servanib manuscript that shows that maybe there still is a role of locoregional therapy, particularly portal vein thrombosis, when it comes to treatment. And in fact, most recently, the Milan group published in the Journal of Hepatology 32-month median survival with radioembolization in hyperselected patients with portal vein thrombosis, something that we want to talk about. And this is sort of our prototypical case where you have a patient that has a large tumor, infiltrative disease, BCLC-C at baseline, as you can see here, and by all guidelines, the treatment and standard of care is a systemic therapy, sorafenib so far, but as Dr. El-Khoury was talking about, several more to come along. But if you implement this therapy, and based on the responses that we see, there are some cases that do extremely well, and you get a tremendous response and a hypertrophy, and now this allows you to generate a narrative that is novel, that is innovative, that is new, and in fact, generate a series of patients that maybe you can now resect after this kind of response. And this is in fact what happened to this patient. He was treated and underwent resection, and now we have 2.5 years of follow-up after resection. So one of the interesting things that we see with the Y90 is a new series of talking points and discussions that we find very interesting and I think significantly advance the field forward, particularly in advanced HCC. Now, we have one study that we performed because there is the need for level 1 evidence with Y90, a small study that we performed, phase 2 clinical trial with time to progression as the endpoint. The study was positive and showed that Y90 was significantly better than conventional chemoembolization when it came to time to progression. And this is data that we described, and as a result of this, have implemented Y90 in our center. No change in overall survival given censoring and patients that were transplanted. Now, one of the struggles that we have with locoregional therapies is the need for not only level 1 evidence, but studies that report on overall survival. But this schematic here really demonstrates the difficulty in performing overall survival studies with locoregional therapies. And you take a patient that has intermediate HCC that is treated with chemoembolization, the standard of care. The patient will progress, we believe, at about 7-8 months based on all the guidelines. And when he's progressed and rediscussed at tumor board, several options are presented to that patient. He then goes on and progresses again on whatever therapy was selected, and now is represented at tumor board with several other options. And now you move on and he progresses again, and now you have this kind of combination. And when you're looking at outcomes on patients that have been treated with 3 or 4 or 5 treatments, it's very difficult to look at the survival outcome on the initial treatment. So it's very difficult to perform randomized clinical trials in early and intermediate HCC. And thanks to the work of Dr. El-Khoury, now we have regorafenib and nivolumab, even complicating the story even further. And I'll be interested in our discussion as to how we implement these sorts of things. Having said that, having worked on this therapy for several years, we believe that having looked at all of our data in over 1,000 patients, looking at our outcomes in early disease, looking at our outcomes in downstaging and radiation lobectomy, and now some of the dramatic effects that we see with portal vein thrombosis, we have decided to implement Y90 as our institutional standard of care. Will we ever be able to demonstrate that using level 1 phase 3 evidence? There's no way we can. However, for granularity, we can present our overall survival in 1,000 patients no matter how you want to look at it. So you can look at it by BCLC staging, which is the standard by the guidelines, or you can look at it in a different way, which I think parallels very much how we look at patients in clinic. You look at liver function on the left-hand side, Child-Pugh A. You now implement UNOS, large tumors, numbers of tumors. You implement if they have portal vein thrombosis, and now you can see their overall survival. And if you want to compare to the standard of care chemoembolization, the survival in BCLC-B, Child-Pugh A, which is about 26 months based on the Brivenib data, is 25 months based on our outcomes. So we think this is competitive, and we think this is sufficient data for us that you can implement that locally. The other interesting thing is if you look at the guidelines very recently, they now start to talk about BCLC-D, Child-Pugh C patients that require transplants, and now we have that evidence here because we transplanted 14 BCLC-D patients that by guidelines, until the recent ones were updated, were treated with best supportive care. So what are the ongoing randomized clinical trials? What is going on? We have those that have been published. The premier trial I just described very briefly. We have the Cervinib and the SARA trials. All of these trials struggle from crossover and intention to treat analysis. But let's go through some of these very quickly. The SARA clinical trial is an attempt to randomize and look at patients comparing Y90 compared to sorafenib in a head-to-head manner. The report with overall survival as the primary outcome. And if you look at the intention to treat and the per protocol analysis, there is no difference. Actually, I should not say that. I should say that it failed to meet the primary endpoint. That is the statistically correct language. Now, we can talk about what the clinically meaningful output is, but it failed to show superiority in overall survival. Same message with Cervinib. This study was done in the East, and they randomized patients from Y90 to sorafenib, a randomized clinical trial, primary endpoint, a superiority study, and also the same message. The study failed. It did not meet its primary endpoint, and this is the conclusion that can be made. And again, we can have good discussions about that in a few minutes. Now, there are a few other clinical trials that we're waiting their outcomes. One of them is the ceramic clinical trial, where you have unresectable HCC at various stages, where you then become randomized to Y90 or sorafenib, and then you follow with sorafenib in the Y90 arm to see what that effect is. We're waiting for these outcomes in the next few years. And the STOP clinical trial, where we take patients that would usually and normally be treated with sorafenib, we randomize them to Y90 plus sorafenib versus sorafenib alone to see whether there is an addition, there's a benefit of adding the Y90 up front with overall survival as the primary endpoint. So how would I conclude what we have with local regional therapies? We have a menu of options we can use. There are various levels of evidence that we have with bland embolization. Chemoembolization, it continues to be the gold standard. Drug-eluting beads, clearly there are many places that use this because of the purported better toxicity profile. We believe that Y90 plays an important role, particularly in this setting that we are talking about, the intersection that Dr. Lencioni was talking about, the intermediate to the advanced patient population. We believe there's a clear role there, even if we have 2 studies that fail to meet the primary endpoint. And my final slide before the moderator comes back is the idea that clearly the combinatorial studies are very interesting. We recognize that. One of our studies we are doing at Northwestern, nivolumab plus Y90, we're looking at this. We've enrolled about a dozen patients now. We understand this concept. Dr. Locoregional described the mechanism of action, and we believe in this, and we're wondering what the outcomes will be. Personally, I think one of the very interesting patient populations that we should look at is actually the patient population that not only has advanced disease at baseline, but the patient population that has metastatic disease at baseline, liver-dominant disease, and use the combination therapy up front rather than stratifying patients into systemic only or local regional therapy only. I can envision that somebody with a large 15-centimeter hepatoma with 2 lung nodules might benefit from the local regional therapy and the immunotherapy systemically or other systemic agents. So this is something of interest. Thank you very much.
Thank you, Riyad. That was a great talk, and I think you really provided the kind of comprehensive overview of how interventional treatment really span the whole spectrum of patients with early to intermediate to advanced HCC. A couple of quick questions before we open up like to a more general discussion. I think I wanted you to make this quick comment, which you touched base at the end, but I wanted to reiterate a little bit the message because there was a lot of discussion even at ASCO GI on this randomized controlled trials, SARA and Cervanib. I was co-chairing the session, so I think you really provided the comment that I think is truly the most appropriate. So the first comment is that the trial failed to meet the endpoint. Then, of course, you can discuss what is the clinical implication of the findings, and also what was like whether that was the right design. I mean, going head to head, because what we are talking here, and again, what has been done in some of the studies, and I think is probably something that it's now on the horizon with the new agents, is really towards combination rather than having a competition between something that has a local effect and something that has a systemic effect. So would you like to comment on that, Riyad?
Yeah, I mean, I think you're absolutely right. I think the reality is the future will be some sort of combination up front for most patients. I think that's where the best outcomes are going to be. Having said that, I think the studies indeed did not show their primary endpoint. And that is the correct statistical interpretation. The designs are very difficult. At the time, sorafenib was the gold standard. There was nothing else. And anytime you wanted to have a discussion about treating macrovascular invasion, for example, the discussion automatically went to sorafenib. The other thing is the guidelines. The guidelines don't really provide you with details as to how to incorporate a locoregional therapy with a drug. They assume treatment 1 and treatment 2, but it's not so simple, as you know. As you could tell from the clinical trials, the intention to treat analysis, a quarter of the patients did not receive the intended treatment in the Y90 arm. Plus, they were delayed by 4, 5, or 6 weeks. And even with that sort of limitation, the survival was 1 month difference. It was lower, but it was 1 month difference. So it's very difficult, I think, to perform head-to-head analyses of a complex, potentially challenging procedure, surgery, ablation, etc., to a systemic therapy. And I think we're going to need to figure out a way to make the clinical trial sort of paradigm conducive to thinking, to creating new ideas and new concepts, rather than just being sort of forced into this is the way you must prove superiority, etc. I think there's always a difference between statistical purity in the discussion, but then the clinical relevance, which came up in SPACE trial as well.
With this, let's focus a little bit. And I think I had this couple of questions that really are probably critical for all of us as intervention radiologists, but also for oncologists and hepatologists and surgeons. I mean, everybody involved in the multidisciplinary management of HCC. So clearly things are going to change. I mean, we cannot ignore that this mounting wave of new TKIs and immune checkpoint inhibitors will clearly have a huge impact. And we really hope that there will be an opportunity to boost survival of the patients. Frankly, I was always a little bit unhappy when looking at, the same way that Riyadh has provided right now for Y90, but for whatever therapy, when you look at survival for the small early tumors, I think he reported in his slide something like 4 years survival with Y90, but there are figures for ablation that are also extremely high, and then there is clearly a gap, significant gap, even for patients with just a little bit more disease. Let's say the intermediate patient will go down from 4 to 2 years. Until now, the best reported results for sorafenib, lenvatinib now in first line is down to 1 year for the advanced. I'm like describing like the big picture, right? Like without, and then we can go into the granularities of details as Riyadh likes to do. But this is like the big picture. So at this point, I think we have an opportunity to do more and to do better. So one key question is patient selection. And I would have the same 2 questions for both of you because I think you can provide, your perspective. So first of all is patient selection. So how do you select patients for locoregional therapy today, considering, the new opportunities for therapies that are available, and has something changed, particularly in that critical area, Riyadh, that you described, the intermediate/advanced, which has always been a long discussion on what was the best strategy. So I would like to pick up your brain on this first point, first Riyadh, and then Anthony on the patient selection.
So I think clearly most of us talk about locoregional therapies in patients that have liver-only disease, patients that have well-preserved liver function. We clearly implement the BCLC categorization, but we will always personalize the treatment, and we probably implement the BCLC categorization implementation about 50% of the time. So I think our approach is to use our tumor board, and we apply the locoregional therapies, as I mentioned in the first slide, in A's and B's, and I believe in C's. Now, one of the things that I firmly believe, particularly since we're at again, the crossroad of systemic and intermediate and locoregional therapy, is early use and early transition to systemic therapy. Maybe that'll come up a little bit later, but I do believe in the concept of using a locoregional therapy and then using and implementing a systemic therapy relatively soon, and having sort of a low threshold to provide combinatorial treatments, because everything is moving towards that. Our best outcomes that we've ever observed are always in some form of combination.
Thank you very much. Anthony, what would be your perspective? Let's say you have your patient that until now was a locoregional therapy, but now the patient is coming and say, I heard that there is a lot of new stuff, doctor. So are you sure you want to send me to the IR, or we can manage in a different way?
Yeah. No, so absolutely, I agree with Riyad that with BCLC A and B, liver-limited disease, limited burden of disease, there is nothing that beats locoregional therapy currently. Where we struggle as oncologists are the BCLC-B patients that have extensive disease, multilobar, even without portal vein invasion. And the question, will these patients have enough liver reserve after multiple locoregional therapies to eventually get systemic therapy and still benefit from it? That's a challenging area. But this is, to your point, Riyad, where we may have the best opportunity for a combinatorial approach to debulk the liver disease and use systemic therapy at the same time. Another limitation we face as medical oncologists is the underlying liver function. There's no question that the Child-Pugh score and the underlying liver function are important prognostic markers, and locoregional therapy, and so does systemic therapy, can have an impact on liver function. And currently, the minute we step outside of good BCLC-B, outside of Child-Pugh B7, it gets murky and it's difficult. And this is where we still have maybe room for improvements and better selection of therapies. I hope this answers the question.
Absolutely. We can probably have this couple of questions before we go to the second point. The first is for you, Riyad. I think it's directed to you, and it's a very direct question. Did you see a change in your practice after the Y90 versus sorafenib trials for your referrals?
So, wow, that is a very good question. I think it's still early, but in our practice, we have not seen a change, and that's because, again, I think the statistically pure way of interpreting the clinical trial is to say that it did not meet its primary endpoint. But I would remind you that several clinical trials prior to the 2002 chemoembolization studies did not meet their primary endpoint and ultimately did. So it's about, Ricardo, what you were mentioning, proper clinical trial design, the right patients to prove that it has an effect. But so far, we have not seen that. And again, you could make a strong argument, maybe not a statistically pure argument, that there is still an important role of Y90 in the advanced disease patient population. The other thing that I highlighted in my presentation is, again, it creates a narrative that is new. I mean, how often now do you see PVT disappear and now patients go on to resection? This is as a result of this kind of therapy. It's not as a result of a systemic therapy. So there clearly is something here. We have to improve our clinical trial design. We have to prove it. And then in retrospect, we'll see that there clearly was an effect. But we have not seen an effect.
Thank you. Anthony, there's a question for you that I think is something that has been a long discussion in the IR community. Because, in a way, interventional therapies are a little bit trapped in between surgery and medical oncology, right? We try to mimic what medical oncology does in designing trials, but sometimes we are concerned that that may not be the best way to do. And one of the problems is the intention to treat analysis. Surgeons have never seen a surgical presentation on the survival for resection of patients who were not resected, right? So in a way, we're presenting as much as we can ITT data. Is this really the best way from an oncologist? I would like to, have your word here.
Well, you touch on an important point, is that even the way we do clinical research may vary a bit from specialty to specialty. And even though the statistical principles are not different, sometimes the way we interpret the data or the way we look at the data may vary. I think the intent to treat analysis from a statistical perspective is the cleanest way to go. When it comes to applicability onto patients, this is where the analysis based on the modality of treatment, how the patients were treated, becomes potentially more relevant. However, the challenge is does this mean it's applicable to the general population when it's not intent to treat? And that's where the difficulty becomes. So I think we have to, as Riyad's alluding to, just start thinking about more clinically relevant endpoints, validate them, and then use those. And I think that's the way forward. from these.
Thank you. This was very relevant to the discussion. Just as a reminder, because in the mentioned Y90 versus sorafenib data, there was kind of a significant proportion of patients, something like 25% or so, of patients randomized to receive Y90 who eventually did not get Y90, but of course they are included in the ITT analysis. Riyad, let me try to wrap up this very intensive session with a question that I'm sure you like it, because probably you and me are among those who have been, struggling for a while on trying to understand what are the criteria to decide when to shift the patient from locoregional to systemic therapy. And again, something that is probably now has to take into account, all the new opportunities for therapy in the medical oncology domain. And so what is your approach, Riyad? And if you like, you can even expand to the concept of sequencing inside the locoregional therapy, because you presented an algorithm which is, really unmasking how complex it is, the management, and sometimes you really wonder whether the classic approach, let's say, to do, I don't know, like a chemoembolization, and then when it progressed to look for Y90 or for, is that the best approach? Should we change our practice? And again, is there something that we can recommend to say when it's time to move from locoregional to systemic?
Yeah, I mean, this is something that we all struggle with, but I would tell you that I'm a firm believer in not just treating with a locoregional therapy 3 times, 4 times, 5 times, and only when there's decompensation to send to oncology. That, I think, is a fair criticism. If it happens, it should not happen. Having said that, I do think that frequent discussion in multidisciplinary tumor board about the patient, that we've embolized this person twice, 3 times, still doing well, etc., and sort of a close-knit discussion is something that can improve outcome on that patient and make sure that the patient receives a systemic therapy before they decompensate. One of the things that we looked at years ago was the idea of, should you wait until you progress to switch, or should you treat before that? And we found that if you wait until somebody's actively progressing for me to then send to Dr. El-Khoury for systemic therapy, half of them have decompensated liver disease. That's too late. So I think there should be a way for us to work together and implement many of these therapies in the adjuvant setting earlier on, and again, sandwich between here and there, because I think this is what we're going to do. The reality is we're never going to be able to demonstrate the validity of this, I think, with level 1 evidence, but I think it clinically makes a lot of sense. We get the collaboration, and we get the integration with oncology, which I think is desperately needed in this field.
Absolutely. Anthony, would you like to make like kind of final comment on this same concept of the transition? I mean, as how the field is moving?
No, I mean, I fully agree with Riyad. I think that the challenge here is kind of having a more uniform understanding of when locoregional therapy has failed. And that's a challenge, right? When do we say it's failed? And important not to keep pushing and miss the opportunity to put on systemic therapy, because now we have multiple lines up available, and it's actually translating into a survival advantage. So that's just important to keep in mind.
Thank you. Thank you very much. So let me wrap up this very intensive session. I would like to thank again the speaker and you all for attending this educational event. Don't forget to apply for the credit.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/ZCA. This activity is supported through educational grants from Bayer Healthcare Pharmaceuticals, Bristol Myers Squibb, and Eisai Incorporated.